A warm welcome to you all joining us live or perhaps on demand for the first of this two-part medical track session entitled The Next Wave, Clinical Updates on New and Emerging Treatment Options in Hemophilia. I am Dr. Stacy Croto, a pediatric hematologist at Boston Children's Hospital and the medical director of the Boston Hemophilia Center. I will be your moderator this evening and have also served as a planner of this year's medical track. This year's medical track is being jointly provided by the Postgraduate Institute of Medicine and the National Hemophilia Foundation. This activity is supported by independent educational grants from BioMarin, Grifols, Novo Nordisk, Sangamo Therapeutics, Takeda, and Unicure. Before I introduce our session speakers for this evening, I want to acknowledge the other physicians who worked with me to plan this year's medical track. Stephen Pipe of the University of Michigan, Mira Chitler of the Children's Hospital of Michigan, and Christopher Walsh of Mount Sinai Hospital in New York. We hope to make this session interactive, and there are two ways for you to participate. Near the bottom of your screen, there is a text box. This can be used to ask questions for the speakers. Please enter your questions at any time, and I will cue them to our speakers at the end of their presentations. There is also a chat box. This will be running for the duration of the session. We will do our best to answer as many questions as we can. It is my distinct pleasure to introduce tonight's speakers. Dr. Mark Redding is the director of the Center of Bleeding and Clotting Disorders at the University of Minnesota Medical Center and an associate professor of medicine in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota in Minneapolis. Dr. Robert Sidonio is the medical director of hemophilia at the Aflac Cancer and Blood Disorders Center at Children's Healthcare of Atlanta and Emory University. Here are my disclosures. Hemarthrosis, and in particular recurrent hemarthrosis, hemophilic arthropathy, and pain are common issues confronting individuals with severe hemophilia, those with inhibitors, and in some cases, even those with moderate or mild disease by severity given laboratory assessment, but with a clear severe disease phenotype by clinical assessment. The propensity of patients with hemophilia to bleed into their joints and then develop chronic and severe degeneration of their musculoskeletal health serves as a cornerstone for the need of prophylactic replacement of deficient clotting factor, or now other mechanisms for boosting hemostasis. This graphic to the left highlights the inside-out inflammation and then degeneration that occurs within joints of hemophilia patients, starting with debris within the synovium, hypertrophy of synovial cells as they attempt to keep the fluid clear within the joint, and then degeneration of the cartilage and ultimately erosion of the bone. The graphic and images here to the right demonstrate the self-accelerating cycle of events that leads to this hemophilic arthropathy. The deposition and exposure of joint tissues to iron given the bleeding, the inflammation and cytokine storm that occurs as a result of that insult to the joint, hypertrophy of those synovial cells, and then neovascularization in an attempt to feed those hypertrophied cells that leads to friable vessels and ongoing propensity of bleeding and ultimately joint degeneration. We also see images reflecting the clinical outcomes, which are the natural history of no or minimal prophylaxis for severe clinical phenotype hemophilia patients. Not only is prophylaxis required to reduce musculoskeletal damage, but the timing of the initiation of prophylaxis is critical. The graph to the left is likely data familiar to you from the landmark joint outcome study led by Marilyn Mako Johnson and colleagues. This study definitively demonstrated a difference in joint appearance by MRI in infants and toddlers who initiated prophylaxis early compared to those managed on demand. Importantly, the recently published continuation data from this study demonstrated that while prophylaxis is critical to protecting joints and slowing the natural history of hemophilia and hemophilic arthropathy, our current prophylaxis strategies are not adequate to completely preserve joint health. The study also highlighted that there is no makeup for late initiation of prophylaxis. Looking at data from across the U.S., one of our most robust databases of hemophilia patients is the AFN data set. These are data that are voluntarily collected and recorded by over 140 hemophilia treatment centers and affiliates across the country. We see that over time, comparing 2016 to 2019, prophylaxis, or at least the report of prophylaxis, continues to increase amongst those with both severe hemophilia A or B and across all age groups. Of note, the extremes of age continue to be a challenge for prophylaxis. You will note, however, a recent spike in the reported prophylaxis rates of infants and young toddlers with severe hemophilia A, likely attributable to recent licensure of a novel bispecific antibody therapy for prophylaxis that's able to be administered subcutaneously. We continue to face a number of barriers to prophylaxis as outlined here, and there may be others that I have neglected to include. Frequency of required infusions for prophylaxis, need for adequate and consistent venous access, adherence challenges, in some cases adherence due to frequency and venous access, but also adherence just due to natural human nature and personality. Perceptions of little benefit, which of course is stronger in certain age groups. Cost and access to therapy remain challenges. Variability in recommendations across various hemophilia groups as to the guidelines for when to initiate and how long to continue prophylaxis, and also the presence of inhibitors. These barriers, of course, represent opportunities for novel therapies and individualized approaches to hemophilia prophylaxis in order to further improve clinical outcomes and disease burden in the daily life of our patients. This is a simplified schema of novel therapies, either now licensed or under ongoing clinical investigation. And these therapies generally fall into one of four categories that I have outlined here to the left. Clotting factor protein replacement, substitution or substitutive therapies, rebalancing therapies, and gene therapy, editing, and other biologic or cell-based therapies. Throughout the medical track, we've tried to highlight emerging data and clinical practice strategy changes from each of these domains. Earlier in the conference, we had an excellent set of presentations and discussion on gene therapy. Here, we will delve into clotting factor concentrates and substitution therapies. And be sure to tune in tomorrow for part 2 of our Next Wave series when we focus on rebalancing therapies. Without further ado, I will turn the podium now over to Dr. Mark Redding for our first presentation.
Again, thank you, Stacy, for the introduction. My session is really focused on what are we doing to improve upon the current treatment platforms we have for hemophilia A. Here are my disclosures. So I think this slide or some version of this slide is familiar to most of you. So this evolution of hemophilia treatment is something that we often talk about when we're talking about where we are now. It's helpful to look back on where we've been. There's a long history of the evolution of hemophilia treatment. I think a lot of us would recognize the 1990s as the advent of the modern era of hemophilia treatment with the introduction of the recombinant clotting factor products. But really, if you take a look at where we are today, starting in 2014 with the release of the first extended half-life clotting factor concentrates, and subsequently the beginning of the non-factor therapy era, in this last 6-year time span, a tremendous amount of new drug development has been ongoing. If we look at this last 6 years in more detail, we can see a number of new drugs that have been released. In the last 6 years, we have 7 new factor 8 products, 4 new factor 9 products, and of course, the 1 non-factor replacement product as well. What I'm going to talk about today is shown here. So I'm going to try to pick a drug from each of the sort of major categories: factor 8, factor 9, bypassing agent, and then a non-factor replacement therapy. There will be more in that latter category tomorrow, as Stacy mentioned. I also tried to focus on drugs that were fairly far along in their clinical development process and drugs for which we have some published data that we can at least talk about. So we're going to speak first about a factor VIII product, recombinant factor VIII FC fused to von Willebrand factor and X10 called BIV001. The factor IX product is delsinonacog alpha or DELS-A. The bypassing agent we'll cover is marzeptocog alpha, sometimes called MARS-AA. And then lastly, a new factor VIII mimetic called MIM8. You can see the companies here that are developing these drugs and then their status with regard to clinical trials. So these are all fairly far along. The factor VIII product, phase 3 also for the bypassing agent, the others in phase 2. So these drugs are moving along quite nicely, and again, we have data from which we can draw and talk about. Before we get into the individual drugs, I just wanted to sort of raise the question of what's really driving all this new drug development. We have had tremendous evolution of hemophilia treatment, as I said a bit earlier, but really what's driving continued development of these drugs is the fact that all of the currently approved treatments require repeated injections given over a lifetime. Stacy mentioned some of the barriers to adherence, and this is clearly one of them. Certainly the development of subcutaneous options has made those injections easier to give, but nonetheless this still involves injections, and I think the repeated nature of those over a lifetime remains a significant barrier, even if it's subcutaneous. The second major thing that drives this is that our goal of achieving zero bleeds has not yet been achieved with any of the currently available therapies, and that's because none of these currently available therapies really offer sustained normal hemostasis, which is really what our goal is. And then lastly, although gene therapy is imminently on the horizon, we're all very, very excited about that. There have been some great sessions so far in this annual meeting about gene therapy. I think it's important to point out that a lot of work still needs to be done before gene therapy is going to be a clinical reality for all. So let's start out by talking about the factor VIII product, BIV001. This is a B-domain deleted recombinant factor VIII FC fusion protein. The FC fusion, as you're all familiar with, is designed to increase the half-life of the factor VIII. In addition to FC being fused to this molecule, there are some additional things attached. The first of those is the D'-D3 domain of von Willebrand factor. The fusion of this to the factor VIII protein allows for it to circulate independent of plasma von Willebrand factor. And so this is a strategy that was used to try to break through the so-called von Willebrand factor ceiling, which has really been the major limitation of extending half-life of factor VIII proteins thus far. In addition to that, there are two X10 insertions which are also designed to increase half-life. One of these is inserted in place of the B domain, which you can see up at the top left of the figure. This is connecting the factor VIII heavy and light chain regions. And the other X10 insertion is really a linker between the D'-D3 von Willebrand fragment and the FC. Before I go further, I'll just say a word about what is X10. This is actually a class of recombinant unstructured biodegradable protein polymers, which were designed quite a few years ago actually, and the goal of these is to increase half-lives of therapeutic proteins. These polymers consist of 6 hydrophilic chemically stable amino acids, which are shown here. These were first described in 2009 and are manufactured by a company called Ammonix Pharmaceuticals. And there are a variety of these that have been used, and the ones that are used for factor VIII may be a bit different than for other proteins, but this is the basic idea behind inserting these linkers to extend the half-life. If we take a look at this figure, we see what happens with thrombin activation. So over on the left, we have the intact BIV001 molecule with all of the parts attached. Upon thrombin activation, the von Willebrand factor fragment and the X10 linkers are cleaved off, which leaves us with factor VIII FC in its activated form. So activated BIV001 is equivalent to activated recombinant factor VIII FC. Let's take a look now at some clinical trial data. So Extend-A was a phase 1/2A single dose study. This was presented last year at ISTH. This is an open label multi-center study which was designed to evaluate the safety, the tolerability, and the pharmacokinetics of BIV001 given as single doses of either 25 units per kilo or 65 units per kilo intravenously. This was a study involving adult males with severe hemophilia A. The subjects received a single dose of recombinant factor VIII, followed by a washout period, after which they were then given a single 25 unit per kilo dose or 65 unit per kilo dose of BIV001. And as you can see, there was a fairly small number of subjects in this study, with 6 subjects in the 25 unit per kilo dose cohort and 9 subjects in the larger dose cohort. Here are some high-level results from that study. The two panels here show the mean plasma factor VIII activity levels over time, shown in days. On the left, we have the results from the 25 unit per kilo dose cohort, and on the right side, we have the results from the 65 unit per kilo dose cohort. The black line shows the results with recombinant factor VIII, and the blue line shows the results with BIV001. And I think just taking a quick look at these figures, it's pretty obvious there's a significant difference between these two. This slide shows in numeric form sort of the high-level results. Looking at half-life, we see that it's about 40 hours, a little bit of a difference between the two doses, but in general, around 40 hours. If you look at the mean factor VIII activity levels at 5 days, it's 12 to 38%, depending on the dose. And at 7 days, we have mean factor VIII activity levels remaining of 5 and 17%, again, with the higher number correlating with the larger dose. Other results from this study showed that the drug was well tolerated. There were no allergic reactions, no anaphylactic reactions, and no inhibitors were detected. These were assessed at day 14 and at day 28. Another study, this is a phase 1 study as well. This was a multiple dose study, again, adult males with severe hemophilia A. In this study, subjects received 4 once-weekly doses of intravenous BIV001 on days 1, 8, 15, and 22. There were 2 dose cohorts. Cohort 1 consisted of 10 subjects who received a dose of 50 units per kilo. Cohort 2 had 14 subjects, and they received 65 unit per kilo doses. PK samples were collected immediately prior to each of the weekly infusions and also at multiple time points after dosing on days 1 and after the 4th dose on day 22. This slide shows the results. Again, on the left side, we have the smaller dose, the 50 unit per kilo dose, and on the right side, we have the 65 unit per kilo dose. The open circles show the results at day 1, and the closed circles or the black circles show the results at the end of the 4th dose on day 22. As you can see, the lines look very similar to the ones I showed from the previous study, and there really isn't any difference between the curves at day 1 or at day 22. Again, looking at the high-level results, in terms of half-life, we see again around 40 hours, give or take, at both dose cohorts. Looking at mean factor VIII activity at 5 days and 7 days, the numbers are much closer together because the doses, of course, are closer to each other. But again, at 5 days, 22% for the smaller dose, 27% for the larger dose, and at 7 days, 10 and 12%. So really significant high trough levels, if you will, after these 4 weekly doses. Again, as in the previous study, the drug was felt to be well tolerated. There were no anaphylactic or hypersensitivity reactions. No inhibitors were detected. And importantly, the factor VIII levels did not accumulate between doses, at least over the course of this 4-week study period. Lastly, I'll just share with you some population PK modeling data from BIV001. This was presented just recently at the ISTH Congress. What they did here is they used data from the previous phase 1 and phase 1/2A studies that I just reviewed with you, so a total of 39 subjects. The data from those subjects and those other studies was used then to do the PK modeling. The modeling was based on a once-weekly 50 unit per kilo dosing regimen, and the chart here shows the estimated time to factor VIII activity levels of 40, 20, 15, and 10%. You can see the time both in hours and in days. This population PK modeling predicted sustained factor VIII activity level in the near normal range for about 3 to 4 days post-dose and around 10% 1 week after dose. So population PK modeling showing similar results to the data obtained in those early phase studies. So a lot of optimism about this one, and we eagerly await the results of further clinical trials which are now ongoing. Turning next to the second drug, dalsinonacog alpha, or DELS-A. This is a factor IX protein. It's a full-length factor IX protein which has a greater potency and a longer half-life compared to wild-type factor IX. And those two characteristics of this protein were achieved through the introduction of 3 amino acid substitutions. 2 of them are designed to increase the catalytic activity of the protein and to improve its affinity for factor VIIIA. The other amino acid substitution causes increased resistance to the activity of antithrombin, which is the mechanism by which this protein has a prolonged half-life. This protein is different from the current factor IX products in that it can be given subcutaneously in a small volume, and it has a prolonged half-life, as I've already mentioned. These are results from thrombin generation assays comparing DELSA-A with both recombinant and plasma-derived factor IX. 3 different colored groupings here show the results of thrombin generation assays with different activators. The solid line is the study drug, DELSA-A. The dashed line is plasma-derived factor VIII, and the dotted line the dashed line is plasma-derived factor VIII, and the dotted line is recombinant factor VIII. And you can see here that the solid line, again representing DELSA-A, shows higher thrombin generation with each of the different assay methods compared to both the plasma-derived and the recombinant factor IX comparators. Turning now to some clinical trial data. These are results from a phase 2B clinical trial that were presented at WFH earlier this year. The primary objective of this study was to evaluate the dose required to achieve a steady state of 12% or greater factor IX activity. And the reason that was selected is because this is the trough level at which if you stay above this level, the likelihood of spontaneous bleeding or bleeding with normal activities is essentially 0, based on data from a number of years ago that I think you're all quite familiar with. Some secondary endpoints determining pharmacokinetics and pharmacodynamics, of course, evaluating markers of thrombogenicity, looking at development of anti-drug antibodies and determination about whether any such antibodies could be neutralizing, and of course to monitor and evaluate for various safety parameters. And we don't have time to get into the details of all of those, but I'll show you some high-level results from these different objectives of this study. So this was an open-label study, again involving adult males with severe hemophilia B, of course. This is a factor IX drug. A small study, only 6 subjects involved in this one. The treatment they were given on day 1, they received a single intravenous dose of the drug at 50 units per kilo, and then that was followed on the same day by the first of 28 daily subcutaneous doses at 100 units per kilo. I should point out here that the volume for all the subjects was quite low. It was less than 1 milliliter for all subjects, so small volume subcutaneous injections given daily. Here's a slide that shows you some of the high-level results from this study. So you can see the 6 subjects shown there, each in a different color. The graph represents factor IX activity over time shown in days. As you can see from the graph, steady state factor IX activity was observed after a bit of fluctuation in the first 7 to 14 days. After day 14, things looked quite stable for all of the subjects. The mean factor IX activity level on day 29 was 19.4%, with a terminal half-life ranging from 60 to 122 hours. Additional results: there were no breakthrough bleeds observed during the dosing or the 5-day washout period following the last subcutaneous dose given on day 28. There were no neutralizing anti-drug antibodies observed. Now, there was 1 subject who had a non-neutralizing antibody detected, but this was without any apparent clinical or pharmacokinetic effect. They did see some sporadic increases in D-dimer. These decreased over time with continued dosing of the drug, and most importantly, they did not observe any thrombotic events or any other significant adverse events. In terms of injection site reactions, there were a few. 1 subject had a reaction that was sufficiently bothersome that he stopped at day 7. The other injection site reactions were quite mild and tended to decrease over time with continued use of the drug. Conclusions from this phase 2B study: firstly, subcutaneous DELSA prophylaxis provided continuously protective levels of factor IX, albeit for a fairly short period of time. The study period was just 28 days. The prolonged half-life of this drug and the stable high levels of factor IX activity do have the potential to allow for less frequent dosing, so perhaps we could do this less than daily and still have good protective levels. And then again, of course, the subcutaneous administration of this drug was felt to be a very major advantage over intravenous infusions. And so again, as with the previous factor VIII drug we talked about, a lot of anticipation awaiting further results from ongoing clinical trials with this product. Okay, turning now to the third drug, marzepticog alpha activated, or MARS-AA. This is a modified recombinant factor 7A drug with, again, 4 engineered amino acid substitutions. 2 of those are designed to increase the procoagulant activity of the protein. This turns out to be about 9 to 10-fold more potent than epticog alpha or novo-7. There are also 2 amino acid substitutions which create a new N-linked glycosylation site, which translates into prolonged half-life of this drug relative to standard factor 7A. And again, as with the previous drug, this drug can also be administered subcutaneously. Let's take a look at some clinical data. We don't have as much for this one because it's a fairly new yet, but we do have data from a phase 1 single dose escalation study. This was actually published a couple of years ago. 25 male subjects, 18 to 64 years of age with severe hemophilia A or B with or without inhibitors. The subjects received a single dose of Mars AA in various dosing cohorts, as you see here. The goal of the study was to investigate the safety and the tolerability of the drug, as well as obtain data about pharmacokinetics and pharmacodynamics, and of course immunogenicity as well. I don't have a lot of results to show you, but suffice it to say that they saw a linear dose response PK across the dose range, terminal half-life of about 3.5 hours. There was a very nice dose-dependent shortening of coagulation parameters, including the prothrombin time and the APTP, corresponding with an increase in thrombin generation as well. Overall, the drug was found to be well tolerated, and there were no dose-limiting toxicities. These are data from a phase 2-3 prophylaxis study with this drug, Mars AA. The regimen here was daily subcutaneous injections with an individualized dose escalation if needed based on breakthrough bleeds. There were 9 subjects who completed this study. In total, they received 517 injections. 1 subject had 97 exposure days, so 3 months is a relatively short-term study. 7 subjects remained at the initial starting dose of 30 micrograms per kilogram. 2 subjects escalated to the next dose level of 60 mics per kilo because of breakthrough bleeds. They had the ability to go to higher doses beyond this, but with the results they saw, they really only had 2 subjects that needed to go to a higher dose from the starting dose. The mean ABR was reduced, as you can see here, from 19.8 to 1.6, and 7 of the 9 subjects had 0 bleeds during, again, this relatively short study period of about 3 months. Again, the drug was found to be well tolerated. There were some injection site reactions in a couple of subjects, but they weren't severe enough to cause them to discontinue. And again, there were no anti-drug antibodies. There are some more recent phase 1 data investigating the use of this drug for treatment of acute bleeds. Very preliminary results from that study were presented both at WFH and at ISTH earlier this year. And so again, we're eagerly awaiting more data from ongoing studies of this new bypassing agent. One of the important questions about this bypassing agent, of course, is will it be safe to use it in treatment of bleeding episodes in patients who might be receiving emicizumab? And so it's a really important question to answer. Here's a nice study that was presented at ASH last year looking at thrombin generation with either Mars AA or Novo-7 or FIBA in the presence of various concentrations of emicizumab or no emicizumab. What you can see here is that, as expected, we knew from the previous data that Mars AA is more potent than Novo-7. So if you look carefully at the graph, the dose of Mars AA is 1/10 the dose of Novo-7. And you can see that the curves, or the thrombin generation looks very similar at that smaller dose. You can also see that the thrombin generation induced by FIBA was much greater than with either of the other bypassing agents. And we see also here that equipotent concentrations of Mars AA and Novo-7 had comparable effect on thrombin generation in the presence of the 2 different amounts of emicizumab they tested. So from these early data, we can get a sense that there doesn't appear, at least at this point, to be any significant issues with regard to the use of this drug to treat breakthrough bleeds in individuals who might also be treated with emicizumab. So again, a lot more data to come, a lot more human data at least, and so far so good with this one as well. Okay, turning to the 4th drug, I want to just spend a few minutes bringing you up to speed on where we are with MIM8. This is a next generation factor VIII mimetic human bispecific antibody. It has the same mechanism of action as emicizumab, which is to bridge factor IXA and factor X, but it's more potent. Robert's going to bring us up to speed in just a few moments about where we are with emicizumab, but this drug is coming, and the main advantage, as I said, is that it's going to be more potent based on the data we have so far. Now, I don't have any human data to show you. We have a fair bit of preclinical data presented last year at ASH. And just to sort of summarize this, again, the main advantage of this drug is that it seems to be more potent than imicizumab. Panel A over on the left shows the results of thrombin assay in hemophilia A plasma. Panel B on the right side shows the results of thromboelastography on blood from healthy donors spiked with a polyclonal anti-factor VIII antibody to mimic the presence of an inhibitor. The blue circles are MIM8. The gray squares are emicizumab. Now, this is actually a sequence identical analog of emicizumab, although the authors of this data did mention in their publication that they had comparable results obtained with a commercially available emicizumab as well. So again, you can see that there's just a greater potency with MIM8. There also are in vitro data. I'm not showing you those results here, but the bottom bullet point speaks to that. In vitro data demonstrating that MIM8 does not seem to interfere with the effect of recombinant factor VIII, so that's good. And also that it behaves similarly to emicizumab, sequence identical analog, in the presence of recombinant factor VIIa and APCC. So essentially what we have with this drug is a next generation bispecific antibody that just is more potent than the one that we currently have available. A bit more preclinical data. This is from an interesting mouse model. This is a factor IX, factor X humanized mouse model. Again, data presented last year at ASH. This is an ex vivo thrombin assay, and basically just again shows that MIM8 seems to be more potent than imicizumab. If you look at the efficacy of a 40 nanomolar dose of MIM8, it corresponds with 300 nanomolar dose of emicizumab. So again, just a higher potency with this particular bispecific antibody. And then here's the last piece of data to share with you. This is again in the same factor IX, factor X humanized mouse model. This is a tail clip bleeding model looking at blood loss, showing a couple of things. Firstly, that blood loss can be significantly reduced after treatment with MIM8, which is important, but also as shown, highlighted on the figure here, that mice treated with a couple of different doses of MIM8 bled significantly less than mice treated with the same doses of emicizumab, again consistent with the fact that this drug does have a greater potency than the currently available bispecific antibody. So an improvement on the existing platform and how this translates in humans, we again eagerly await. The phase 2 study is starting to enroll, I believe, just in Europe. I don't think it's available here in the US yet, but we're eagerly awaiting further results from ongoing studies of this drug as well. So in summary, I've given you a glimpse of some new drug development in hemophilia. I think it's safe to say that we've had a tremendous amount of new drug development over the last several years, and that continues ongoing at a very strong pace. Emerging data, some of which I've shown you here, shows very promising improvements to our existing treatment platforms. And again, why is this happening? This is happening because sustained normal hemostasis is not provided by any of our current treatment options. And again, as I mentioned at the beginning of my comments, we're very eagerly awaiting the results of gene therapy studies, and we're anticipating the approval of gene therapy. But I think it's fair to say we still have a lot of work to do, a lot of problems to be solved, and some questions yet to be answered before gene therapy is going to be a clinical reality for all of our hemophilia patients. And so between now and whenever we get to that point, there is still plenty of room for improvement on the existing treatment platforms that we have. So with that, I'll close my part of the session. I want to thank you for your attention. I will gladly turn over to Robert.
Thanks, Mark. So I'm going to take it from here. The focus, let me get my slides oriented here. So the focus of my session is going to be specifically on emicizumab clinical trial updates. Most of you already know the ones that are from the sponsored trials. We're going to talk about a lot of the investigator-initiated studies that have come after the emicizumab HAVEN trials. As mentioned, I'm Robert Sidonio. I work at Aflac Cancer and Blood Disorders at Emory University. So these are my disclosures. I'll leave them up there for a second. So I probably don't have to tell this audience that much about emicizumab, but I think it's nice to sort of make sure we're all on the same page for those that are not physicians or not familiar with the drug. So this is a bispecific monoclonal antibody. It's similar to the one that Mark alluded to about MIM8. It restores coagulation by bridging activated factor IX and factor X and replaces or mimics the function of activated factor VIII. as expected and has been shown, it's not expected to induce factor VIII inhibitors because it's structurally not the same as factor VIII. It's administered subcutaneously. It was the one non-factor product that was alluded to by Mark that was approved in the last few years. It has a long half-life, approximately 28 days, which allows for once weekly, every 2 weeks, or every 4-week administration following loading doses. And it's the only product at this time that maintains a fairly steady state, protecting patients from bleeding events. And so it's the closest thing that we have to that sustained protection. And of course, at least in the United States, it's approved for prophylaxis in patients of all ages with hemophilia A, with and without factor VIII inhibitors. So, over the last few years, we've had a number of clinical trials, starting with Haven 1, which is the adult trial, 12 and older, and those older with heavier than 40 kilos with inhibitors. That data was published, and that looks specifically at weekly dosing following the loading dose. Haven 2 study followed soon after, and one study that we participated in which children under the age of 12 and those that are below a certain weight between 12 and 17 were allowed to participate. It was looking at once weekly regimen, but there was also an additional cohort that looked at every 2-week and 4-week dosing. And then Haven 3 and 4 tried to get a little bit additional information, particularly those for older than 12, focusing on different regimens and attempting to get additional kinetic data. And so right now, this is the largest clinical program of hemophilia patients with and without factor VIII inhibitors. As you can see, the numbers are quite staggering, how many patients have participated in these trials, of which all have been completed, and most of the clinical trial data has been published. So what's next? Haven 6. This is a study, so I had to create the schema because one doesn't, I believe, doesn't exist yet. But this is a study that's a sponsored study, so a Genentech study. It's a study to evaluate the safety, efficacy, PK, and pharmacodynamics of emicizumab in patients with mild or moderate hemophilia A with or without factor VIII inhibitors. And it's important because all of the patients previous to this without inhibitors were patients with severe hemophilia, and there were some patients with non-severe hemophilia if they had developed an inhibitor. So there's no age restriction, as my understanding, looking or reviewing the lay summary. The weight is greater than or equal to 3 kilos. You could have mild or moderate hemophilia A, and they're going to have specific restrictions to throttle the number of patients within both of those platforms. Importantly, you notice there's no gender restriction here, and so there will be carriers involved in the study, hopefully, potentially with mild hemophilia. You cannot have a documented inhibitor within the last 5 years. You have to have a fairly good CD4 count, and you cannot be pregnant or breastfeeding. So that the restriction is no pregnancy or breastfeeding during the study. It's unlikely it'll be an issue, but for ultimate safety, that's something that's not going to be studied during the conduct of the study. So the patients, there'll be approximately 70 patients. They'll undergo the exact same loading regimen as the current label, which is 3 milligrams per kilo weekly times 4 weeks, followed by a maintenance regimen of 1.5 milligrams per kilo weekly, 3 milligrams per kilo every 2 weeks, or 6 milligrams per kilo every 4 weeks. This will be non-randomized, and they'll have multiple cohorts that will be followed for at least a minimum of 52 weeks. There'll be approximately 70 patients involved in the study. So one of the things I think that we, just for context in the subsequent studies, one question that comes up to me a lot is about early controlled low-dose exposure to factor VIII. There's an idea that maybe this could potentially lower the inherent cumulative incidence of inhibitors by exposing the patient to factor VIII in a non-stressful environment. We know that approximately 30 to 40% of pups with severe heme will develop an inhibitor no matter what we do. We have various ways to evaluate that risk, but we don't have a really good strategy to mitigate that short of a plasma-derived product in a patient that has low risk. We know that the majority of patients develop them in the first 30 to 40 days, and almost all of them certainly will have developed it by 50. And there are a variety of factors that the patient has control of, and a variety of factors that are inherent related to genetic markers that the patient has absolutely no control of. Typically, when we start prophylaxis, it's sort of a stepwise approach. Many of us do once or twice a week, allowing the patient, the family, and everybody to get used to this and increase as quickly as possible, or at least as feasible. And definitely this is significantly modified by the availability of the veins of the patients. The Germans, Koenig's group, early part of this decade, can't believe I'm saying that, in 2010, they thought that if the nurses were the ones giving the doses during a quote-unquote tolerization phase, if you avoided the danger signals like immunizations and large bleeding events, you may be able to not avoid inhibitors or reduce it significantly. And they actually did show in their single institution study that strategy seemed to be feasible, but as that with any sort of study hypotheses, it needs to be expanded to multi-sites. And it was done in this study that was published in 2015. They attempted to give a dose of 25 units per kilo of factor VIII to pups starting before 12 months of age. They had to be weighed and the dose had to be exact. They were not allowed immunizations at the time, and they were hoping to reduce inhibitor incidence by 50%. This was a phase 3 trial, historically controlled, single arm, and was stopped early because 8 of the first 19 subjects developed an inhibitor, giving you the exact same incidence as previous data. And if you looked at the number of confirmed inhibitors with definitely proven factor VIII binding antibodies, it was still a significant percent. There was no way that they were going to demonstrate this in this study setting. And so the study ended early. And the reason that they bled is they have hemophilia. They're going to bleed. You can't give 25 units per kilo if they have a large bleeding event. And the majority of the patients bled when they were on weekly dosing. And so that's the problem with this design. And hopefully this will be something we could potentially evaluate in another study that we're going to talk about in a minute. The other issue that I think needs to be discussed before mentioning the studies is that pups that receive emicizumab will certainly have delayed factor exposure and thus have delayed factor VIII inhibitor development. At least that's what's thought. Because of this idea and concept, we decided to perform a cost utility analysis and evaluate this using mathematical model, inserting data from the Haven 2 trial, and making some reasonable assumptions and evaluating cost. For the purposes of this presentation, I'm going to focus only on one of the important data, was that on average, a patient that was on factor VIII prophylaxis would reach 20 exposures in about 4 months. I think that's pretty reasonable. Most people would assume that's about right. If you're on emicizumab prophy and they develop the number of infusions that typically were seen in the study, it may take 13 years to get to that same factor VIII exposure. Certainly in the study, patients were avoided factor VIII exposure because that means they had to come back to the clinic and be evaluated. And so certainly, I don't think it'll take 13 years, but it may take 8 or 9 years before they reach the time to develop an inhibitor. And so we don't know what that's going to do with inhibitor development. We don't know if that actually may reduce it or not. One of my former mentors, Dr. Maggie Ragney, who's in University of Pittsburgh, has designed and funded a study. It's called the Inhibit Trials Platform. She was able to get NIH funding and applied adaptive clinical design to this. Initially started off as an aloctate study, and then along came emicizumab and altered the way we think about inhibitors and the way we treat patients. And so in this study, hemophilia A pups without an inhibitor will be randomized either to aloctate for 48 weeks or emicizumab for 48 weeks. The primary outcome will be the time to inhibitor development. If the patient develops an inhibitor, they'll go on to a second portion of the study. If they don't, then they're done with the study. The second part of this is, so the initial part is the prevention trial. The second one is the eradication trial under the Inhibit Trials platform. And so that inhibitor patient will come all the way down here, and they'll be randomized either to aloctate ITI with emicizumab, so utilizing sort of the standard Atlanta protocol, or using the traditional factor VIII ITI regimen utilizing aloctate, which has been shown to potentially be a faster form of ITI if you're using it by itself. Additionally, you can see here in which the primary endpoints will be evaluated. There'll be 33 patients involved in the randomization in the prevention study. You can see here the primary endpoints and the secondary endpoints and the determinants of the sample size. And you'll see the eradication trial will randomize 45 patients to either one of these arms in which they get ITI plus or minus emicizumab. And the Eloctate ITI will be every other day, and that'll be similar to the Atlanta protocol when it comes to the emicizumab plus arm. So maybe I should have shown this slide before. One of the questions that still remains, I think some of us have leaned toward this idea of the answer being yes. Will ITI be relevant in the age of emicizumab? And this is a question that came up years ago, certainly while the Haven 2 trial was underway. We had a patient that had, I believe, gotten 2 doses of recombinant 7A and had not attempted ITI, developed an inhibitor, and within 4 weeks was enrolled in the trial. And so it was difficult to discuss to this family what is the purpose of ITI, because they were doing relatively well on emicizumab and they felt like they were living life without an inhibitor, when we all know that's not exactly true. And so, guidelines, at least ones, before emicizumab, recommended that it should be allowed and should be considered. We know that NHF in the past has mentioned it should be started as soon as possible after the high titer inhibitor has been identified. We certainly don't wait until the titer has dropped unless we're waiting to put a central line in. And we should be at least considered in all patients, particularly the pediatric patients. There's still some discussion on whether all the adult patients should be considered, because that does get quite expensive, and some of the adults may not be interested in undergoing such a rigorous regimen. There are a variety of ITI regimens available. We know that you can see here the bond protocol, which my colleagues in Germany are still utilizing, and they actually often will give 100 units per kilo every 12 hours, meaning that they'll access a central line and infuse the factor. They'll de-access it. At night, they'll re-access it again, giving the second dose, leave it accessed overnight, and then de-access it again in the morning. So it's a quite difficult regimen for the child and quite a lot of burden on the family. And the Malmo protocol is not really done that often. I'm only aware of one site in the United States that still attempts part of the Malmo protocol. And then a lot of us do sort of iterations of the Dutch protocol somewhere in between. Most of us in the United States are doing dosing about 100 units per kilo every day or every other day, depending on the titer. We know that once emicizumab came along, our center conducted a study, a small institutional study, in looking at the utility and the safety. We chose 100 units per kilo 3 times a week. We felt like the 3 times a week is a regimen that hemophiliacs understand and know and are likely willing to accept. We certainly think that if you gave it every day, you can probably achieve tolerance faster, but it's unlikely that a lot of patients will be interested in that strategy now that emicizumab is allowed for infrequent IV administration. So the Grifols group put together a panel of providers, I believe is led by Dr. Karkow, and then Dr. Young and Carmen Escarola were involved in this. And I'll take you through what their recommendations were. So the current strategy in the pre-emicizumab era is, if you develop an inhibitor, you start ITI. Some of us follow this very specific regimen that typically dumps into the same dosing. So I'm not sure if it matters how much if you label them prognostically. But regardless, if you're giving 50 units per kilo 3 times a week or as high as 200 units per kilo, you undergo that regimen and you start as soon as the inhibitor is detected. If you escalate the dose, if the inhibitor titer rises, and then at around 6 to 9 months, you really have to make a decision whether there's at least a 20% drop from the peak titer. And oftentimes, this is where the family will want to know whether they feel like it's worth continuing this. And certainly in the emicizumab era, many families are not going to tolerate long terms of time periods of ITI without emicizumab. And then you evaluate the success over time, typically around 3 years, hoping that you at least achieve partial success to success. and determining whether you want to move on and do chronic ITI, for lack of a better term, to control it. And we don't like to use the word failure, but obviously that was determined based on clinical trials. And certainly the new proposal is different. This was published actually before our paper came out. Patient develops an inhibitor, and they certainly could just start emicizumab, move on, and consider ITI later. If they decide to start the combination protocol, in which they give as low as 50 units per kilo 3 times a week, our recommendation would be to start at 100 units per kilo 3 times a week. We've had a few patients that started off and they had a more of an anamnestic response than the others and didn't seem to respond as well. Regardless, you escalate as high as 200 units per kilo daily. I'm unlikely, and I'm sure my colleagues in Atlanta are unlikely to escalate that high of a dose, but that's something that I know our German colleagues have had a good results on there, and you have to follow those patients very closely to reduce the risk of thrombosis in the port. You have to make a decision probably around 6 months. If you don't get a good drop in peak titer, you're not moving in the right direction. A lot of families are not going to continue this indefinitely. And certainly you would assess around the same time. It's not unlikely to see patients stop their ITI. Maybe something happens like COVID, they need a break, and then they resume it, when COVID is handled, hopefully after this election. So the protocol that we came up with, and we labeled it sort of in the tradition of labeling it after the city in which it was developed. It was led by our young investigator, Dr. Glavy Batsuli, and Karen and Shannon and Kelly were involved as well in this study, and were critical to conducting the study. But you can see we would start the patient on emicizumab, or they may be on ITI already, in which we would pause at emicizumab, and then we would resume ITI only after they've gotten to the maintenance phase. And certainly patients have started emicizumab and not started ITI for 6 to 12 months, which is certainly not an issue. If I had an inhibitor, I'd want a little break before I did IV infusions. So out of that came our study, which is called the emicizumab PUP and New Week ITI study. And we really wanted to look to see, is it feasible to reduce the inhibitor incidence, as I mentioned, with a structured low-dose factor VIII regimen? So the EPIC study was unable to do that. It wasn't for lack of effort. They didn't have the proper drugs to be able to control the bleeding and allow the hypothesis to be tested. And you can see my esteemed colleagues on here, Drs. Meeks, Shapiro, Callahan, and Dr. Manco Johnson. So this is part A of the study. There'll be 40 patients from about 13 centers. There'll be male patients with moderately severe Hem A under the age of 3. They can have only up to 2 factor VIII exposures or single exposure to a blood product. They can have no documented inhibitor, and they have to have adequate function. So this is the PUP portion of the study, and we certainly don't want them to have another bleeding disorder as we would expect in a clinical trial. This one is a fairly straightforward study. They'll start off at emicizumab as soon as they want. If we want to enroll this patient on week 4 of life, we certainly could. It might not be feasible, but it's something we certainly could. We start off with the label dosing for loading. We continue with the maintenance dosing. It's sort of dealer's choice. It doesn't matter what the regimen is chosen. Typically, it's going to be probably 3 to 3 per kilo based on most of the young children. The rounding typically ends up being that. And we have rounding recommendations as well. There's a little bit of loose recommendations allowable in the loading dose, so we really want this to be a feasible study. And then we'll expose them as part of our factor exposure program. After at least 3 to 6 months of Hemlibra, or certainly they can start it before, they'll be exposed as provided by Octapharma. Simoctacog alpha will be provided, and they'll be dosed either weekly or bi-weekly. Intravenous infusion, either with the specialty pharmacy or the clinic, or certainly by the parents. And that dose will be 25 units per kilo every other week or every week. And they'll continue their emicizumab until they reach the 50 exposures or develop an inhibitor or whatever's first. And it rounded up to about 56 exposures just for lining up depending on the visits. And then you'll use the Simoctacog for on-demand use. So this study will provide the Simoctacog, and since emicizumab is on label, it will be prescribed by their local provider. And certainly the programs can help if there is an issue getting it for the pup. So that's part A of the study. We decided we wanted to make it a longer study and make it more inclusive, and have part B and do a more formal multi-center evaluation of the Atlanta protocol. And so in this part, we want to see, is it feasible to combine factor VIII with emicizumab to achieve tolerance? So this is a 1-year study. We're going to have 20 patients. And again, we're going to be provided Simoctacog from Octapharma to allow us to dose the patients 100 units per kilo 3 times a week for 12 months. Certainly patients may decide to continue going on after that. As everybody knows, that is a lot of factor to be provided, and we're hoping at that time that will allow them to continue on utilizing their local insurance or maybe potentially through a factor program. The patients could be any males of any age, moderately severe hemophilia A, and we're really looking at sort of primary ITI. We've had a lot of discussions about this, but just for the sake of comparison, when we're only talking 20 patients, we want to focus on those primary ITIs, the ones that just started, we certainly would like to do a refractory ITI study sometime in the future. And so here's the schema again. You got your loading dose, your typical maintenance dose. Most of these patients will likely have started these before enrollment. And then the Atlanta protocol, which is Simoctacog alpha, 100 units per kilo. That can be given in the morning or night, but it has to be given 3 times a week. Approximately. Typically, we're recommending Monday, Wednesday, Friday, since they don't need it for hemostasis. And they'll continue their emicizumab. They'll be prescribed locally the recombinant 7A as they get acute bleeding events, and they'll be dosed per the local recommendation, obviously allowing for low-dose APCCs if there's a lack of response to recombinant 7A. So that's that study. So I'm the lead on that one. And there's another emicizumab study. This is an investigator-initiated prospective study, and I probably should have put what the MOTIVATE stands for because I often forget. I think it's on the other slide. But our goal in this study is to characterize ITI strategies with and without emicizumab. So certainly the study that we had, I just mentioned, we'll be able to look at it in a very, very limited clinical setting. We wanted to expand this, and so my colleague Carmen Escarola Eddinghausen in Germany, we wanted to have a larger international study to really demonstrate that this strategy is one that's going to be feasible. So this is a 5-year study for each patient, potentially a total of 10 years. And patients will be enrolled from approximately 30 centers, 120 patients, males of any age, any severity, as long as they have a high titer inhibitor. And you could have been on a primary or refractory ITI. And there are multiple arms that we're investigating. There's the acronym, I always forget it. Modern treatment of inhibitor-positive patients with hemophilia A. We had to stretch to get all those letters in there. So, so you can see I'll be in charge of domination of US and Canada, and Carmen will be in charge of the EU and make sure that they're all in line. And we have a pretty good steering committee, as you can see there, some pretty well-known physicians that are involved. This is technically 2 trials because it was considered a low interventional pragmatic trial in Europe, for whatever that means. I've never known what a pragmatic trial design is, but apparently that is one. And so, so we had to make them 2 studies, but the data will be pooled and it will be exactly the same CRFs. The objectives are fairly straightforward. We want to look at the safety, efficacy of standard of care ITI versus novel ITI. We want to compare safety and efficacy of EMI alone in inhibitor patients. So we had a control arm. And then we want to have a lot of different sub-studies that we'll talk about, focusing on joint and bone health, the questions that we've had about factor VIII and its role in osteogenesis. And we certainly want to look at the risk for thrombosis, as certainly this has been a topic of discussion over the last few years. We know that there's a risk in inhibitor patients alone, and certainly we want to see if emicizumab or ITI with emicizumab contributes to that. So you can see here, the arm 1 is ITI with an Octapharma product. These products won't be provided, but will be prescribed locally. And then on-demand treatment could be whatever you want to utilize, APCCs, recombinant 7A, high-dose factor VIII. That's totally up to the provider. We don't decide. If you change arms, they change arms. We really just want to collect the data in a real-world setting. The Arm 2 is the ITI or the Atlanta protocol version, so emicizumab plus an Octapharma product. And then Arm 3 is routine prophylaxis with emicizumab. We want to capture low-dose APCC use. We want to capture recombinant 7A. And certainly, again, this is all up to the local investigator. The primary endpoints are the same ones of every ITI that's ever studied, that's ever existed. And we're going to look at ABRs and compare them among the groups. And so it's quite a large undertaking, and we know, but we really feel like this could be a really important study. We wanted to get in front of the issue instead of doing 35 retrospective studies and then having a bunch of multi-center analysis with contradictory results, which I think is what we did basically in the last decade. And so we really want to get in front of this issue and really show if this strategy works earlier rather than waiting a decade and figuring it out. These are all the different outcomes we're going to evaluate. So there will be allowance for joint ultrasound, musculoskeletal ultrasound. We're going to look a lot at safety. We're going to look at bleeding episode treatment. And we certainly are going to have a number of sub-studies I think that will be quite interesting. There's going to be an e-diary that's available. And we hope that having so many free labs involved is really going to be helpful and encouraging for patients because they'll be genotyped, there'll be thrombin generation, and various number of other free labs that will be available for the patient. So that's ITI. I'm hoping in a few years we'll be talking a lot about these patients in post-ITI. And a lot of people are asking what happens, is there data to show that tolerance persists after those 50 exposure days? Is it safe to stop exposing patients to factor VIII or having limited intermittent exposures only during bleeding events? And then the other question that we have is once you're tolerized, how much factor VIII exposure is needed? Every time I ask an immunologist, they tell us that you can never stop it. I think they're going to be proven wrong on this. And we certainly have seen patients that have been tolerized a few years ago switch to emicizumab and have no demonstration of measurable functional inhibitors. And so it's really important that we answer this question, and that's why it's really great that we have so many people answering this. We know historically in a study led by our center, the relapse rate is quite variable, and there didn't seem to be any evidence that post-ITI factor VIII prophylaxis adherence predicted relapse. I think if we repeated this study, I think probably would demonstrate that that's probably not the case because we know that we probably didn't do as good of a job of getting good washouts and measuring so these low titer inhibitors that may be hard and are more difficult to measure but can be measured better now in better labs. So Guy Young and Handy are conducting another study that's just about to get started. So if you have any interest, please contact them. It's registered on clinicaltrials.gov, I believe. It's called the Priority Study. It's a randomized control study of post-ITI factor VIII exposure. So once you've tolerized and once you finish with our studies, then you can enroll in Guy and Handy's study. And this is going to be conducted out of Los Angeles. They're going to be comparing weekly factor VIII to no factor VIII. So once the patient is tolerized following their high titer inhibitor and they achieve all of the typical outcomes of no evidence and have full success in achieving ITI, they'll be randomized either to weekly factor VIII exposure or no factor VIII exposure, followed prospectively for a return of factor VIII inhibitor or not. And so this is definitely a study that we all want to see what the results are. It's going to be a really important study. So if you have any interest, they're looking to enroll 52 patients from 20 centers. It's certainly not an easy study to conduct, but I think it's a great question to ask. And so with that, that's the end of our presentation. So hope everybody keeps their distance, but we want to stay close. That's what these meetings are all about. So feel free. I think I'll turn it over to Stacy, and she'll take it over and help try to moderate Mark and I for the questions.
Excellent. Thank you both for those really excellent presentations that were just jam-packed full of exciting information. We have a bunch of questions. I'm going to try to cluster them together in a sensical way, but we'll kind of take them as they come. I would also remind our audience that the chat and the text box are there at your screen. Please do keep the questions coming, and we'll do our best to answer all of your questions as they come in. So the first question, I think it's actually nice that we happen to have a pediatric provider and an adult provider, so I'd love to get both of your perspectives on this. But folks are interested to understand, how do you help engage patients in shared decision-making over prophylaxis with so many different options available? And maybe to make it simpler, we could even just think about options in terms of, you now have standard half-life products, extended half-life products. If you're hemophilia A, you have a non-factor replacement product. We have a whole host of clinical trials, whether it's gene therapy, some of the factor products that Mark spoke about. How do you engage? I guess we'll start with Robert, your pediatric population, and then Mark, maybe you could get some insights on the adult population.
Yeah, so I'll start it out. So it's a great question. You know, we all know when we have that new patient with, you know, severe hemophilia A particularly, you know, that first conversation is quite a lengthy one. Even 15 years ago, it was pretty short, right? There were only a few factor products. They didn't really have much of an option. It was either plasma-derived product or recombinant products. And, you know, we had limited information, and certainly we got some from the SIPA trial. The typical way that I sort of approach it is that, you know, I think it's going to take multiple visits. I think the shock of being diagnosed with severe hemophilia A, even if they know the mother's a carrier, it doesn't matter. They're probably not hearing a lot in that first hour or so when you're discussing all these things. And, you know, I think it's important to have multiple conversations. You know, telemedicine is certainly going to help that, because we can have a quicker follow-up instead of waiting to come to clinic, which is a challenge with a young baby. But I think, you know, the way I sort of talk to the patients is that, you know, in the past, I sort of see this as the golden age of hemophilia. You know, Mark talked about the modern age starting in the 90s. I really think this is the golden age. There is so much interest, so much investment from the pharmaceutical industry, and there's so much good advocacy from these patient groups, and so much interest in trying to do a better job than their parents or their grandparents. And so they should be glad that there's so many options for them, that they have a choice. This isn't always available in other disease entities. And it's really important to stay engaged, and we try to mention any new products. Even if families have absolutely no interest in switching products, I think they need to hear what's new and what's happening, and we should continue to stay engaged with that. And they certainly should find their local chapters, and they should make sure they keep up. And there really isn't a lot of good reasons they can't keep up with the virtual world that we're living in right now. You know, you barely have to be half dressed to be on these things just from up here, right? And so I think it's really, the virtual meetings have really helped, I think, patients to stay engaged. You know, you go to these meetings and then you bring your questions back to the providers. Don't use our names when you say that, but definitely we want people to do that.
Yeah, this is a great question, and I think it's one that the answer to it has really changed in a fairly short period of time. So, you know, our center, we just see adult patients, and so my focus is really on that population. And I think a lot of the things that Robert touched on are relevant to the adult population as well, but there are some differences as well. You know, I think shared clinical decision-making is the key. I mean, Stacy mentioned this in the question. And for me, the real issues are, I think, in two categories. First of all, is the patient on prophylaxis, yes or no? And if they are they adherent to prophylaxis? And if not, why not? If they're not on prophylaxis, then why not? And what can we do about that? So, you know, we have to start by figuring out what the patient's goals are, and make sure that whatever we talk about always keeps that in focus. We obviously have our agenda, we have our, you know, things that we think are the most important, but if we don't get in sync with the patient from the very beginning, you know, we can talk for hours and not make a lot of headway. And then that's really what shared clinical decision making is all about, right? It's about making sure that we're both on the same page, making a decision together versus me saying, here's what you need to do. That never worked. The second thing I would speak to with regard to this broad topic is, yeah, it is very overwhelming. I mean, there's an overwhelming amount of information. It's hard for us to keep up with this, and I think the three of us are similar in that this is pretty much all we do is bleeding disorders, and I struggle to keep up with everything. And so, the amount of information out there is huge, and as Robert said, it's easily accessible. I think that kind of works in two ways. In some regards, it's good because there's always potentially something better. But on the other hand, I've also seen that overwhelming amount of information result in people shutting down because they just can't consume it all. And again, this is something you have to figure out with the patient. Some patients are very keen on hearing the newest thing and always looking to sort of like make it better. Others are very satisfied with what they're doing. I mean, we still have some patients on some of the first and second generation recombinant products, standard half-life products, and they're doing fine. And so just recognizing that spectrum of where people are is really important, and then coming at them with the new information. I think the last thing I think that's important to recognize is that the needs of the patient, the goals of the patient change over time. With young children, obviously it's all about protecting joints and preventing bleeds, and then they get sort of handed off to us as adults, and adulthood isn't sort of a static thing either. People go through various phases in terms of their activity level. People go through various phases as they get through their career, starting families maybe. And then as they get older, other medical problems develop, their activity levels change, their goals in life change, and we have to adapt our approach to fit all of those things that are changing. Unfortunately now we have adults with hemophilia living to old ages, and we have to figure that out as well. So. But I don't think there's really a straight yes-no answer to this question. I think it's really just a matter of recognizing all of these facets that really contribute to it. And really, again, shared clinical decision-making is the only way to get through this.
Absolutely.
Excellent. This is a bit of a forward-thinking question, but given the great data that you presented for BIV001 with once-weekly infusions and such high factor VIII levels, do you think that there is a role for using, or perhaps investigating might be a better but for using BIV001 for exposure days in infants prior to initiation of emicizumab for primary tolerance?
Ooh, that's a tough one.
It's a data-free zone. You guys get to have your open.
Yeah. This is all strictly just personal opinion with absolutely no data to back it up. But I mean, as Mark sort of mentioned, once it sort of becomes active, it essentially becomes a sort of extended half-life product. And with all those modifiers, obviously we're going to march downward from the studies to the younger ages to demonstrate that it's not going to induce inhibitors. That's going to be the thing that we know, because we certainly know that subcutaneously injected factor VIII seems to stimulate inhibitors, and certainly some of the extended products have had issues with reactions and inhibitor development. And so, I mean, I think if there's a competitor for emicizumab, BIV001 is definitely there, and there'll be people that are interested in that have no interest in emicizumab but really want a slightly more traditional factor VIII product that's obviously going to be administered intravenously. And so again, it offers choice for patients that maybe want to be a little bit closer to factor VIII, and those that aren't as interested and don't really feel like tied to factor VIII. And so I think it could be something we look at, but first of all, we got to do the studies in children, which haven't even been done yet. So yeah, maybe in the next NHF we can talk about that.
That's
it. I'll just add a couple of comments on that. I think Robert's right. I mean, we don't have data, so it's hard to say much, but from immunologic perspective, I don't know that the level matters. I mean, it's the protein is there, and whether it's in high amounts or small amounts may not matter from an immunologic perspective. We don't know that, but I would bet that the amount isn't as important as just the presence of that antigen, so to speak. And then just to dovetail on your comments, Robert, about in terms of where this particular product might fit in the space of perhaps competing with emicizumab, I do think there's a role in that regard. The advantage of it is that you would have the benefits of getting peaks and yet still have troughs that are well above a protective threshold ideally. And so we have some of our young adults who are physically very active and really need those peaks, and yet they want better trough than our current factor products often can offer. And so perhaps for that subset, this would be the preferred drug. So a lot to learn about it still. Obviously, it needs to be approved, but there are unique subsets of patients for which one of these new therapies might be a great fit, and for others they may have 2 or 3 to pick from. So the more treatments we have, the more we can tailor our treatments to the individual, which I think is a great problem to have.
Yes, the variety is nice.
Excellent. Mark, I actually have a couple of, I think, short but specific questions for really directed towards your presentation.
Okay.
Do you know anything about DELSA and its distribution, sort of intravascular, extravascular, and its interaction with collagen 4?
No.
Okay. Me, I don't know, Robert, if you have any insight.
Yeah. No.
The pharmacokinetics of factor IX are obviously much more complicated, and we don't know enough yet, but that's a great question. It's something we definitely are going to have to look into.
Yeah, there should not be a difference, but again, we'll have to see what happens in clinical trials. So.
Is there a potential for use of Mars AA in severe factor VII deficiency for prophylaxis or for bleed treatment? I think you focused a little bit on it as a bypassing agent.
Yeah, I mean, certainly that's a natural potential extension of the experience of this drug. As you know, that's a very small population, but one for whom we could desperately use a better prophylactic strategy. So I can't speak from direct knowledge, but I would assume that's on the radar for the folks developing that drug.
I mean, it would make sense that you would do that, and currently we do have some patients on it. Typically, it's following a devastating intracranial hemorrhage, and it is always surprising to us that 2 to 3 times a week low dose 7 seems to be highly protective. And so it'd be very interesting if they do a trial. I'd be really would want to figure out this. How does that protect, those patients? Because it's certainly that, we always worry about, are we giving enough, or potentially could we reduce the frequency? So.
And just to clarify, Robert, when you said you have a few patients on it, you meant more just 7 replacement, not Mars
7,
AA.
yes. Yeah, with congenital 7 deficiency. So when I see that data, I think the same thing that person asked that question. So.
And then Mark, I guess I'll throw this to you, though you didn't speak about it specifically, but someone had a question about 7-FACT, which was announced recent approval by the FDA this spring. And they were just curious what, if any, information that we had about the safety, efficacy, dosing regimens for this new 7 replacement.
Yeah, no, great question. I'm glad that someone brought it up. I certainly didn't mean to exclude it. I was trying to focus on things that weren't yet approved, but as you said, Stacy, this is a recombinant factor 7A that was approved, I think, in April of this year. It is developed by a French company, LFB, and I believe the marketing rights in North America are through Hemophilia, if I'm not mistaken. The difference with this drug compared to Novo7 is that this one is produced in genetically engineered rabbits, and the mammary gland of the rabbits produced a protein, so it's isolated from rabbit milk. So that's kind of the twist on the development of this. I believe the dosing is very similar to Novo7. I think the dose for a bleeding episode is 75 mics per kilo every 3 hours until hemostasis is achieved. I know the studies looked at a larger single dose of 200 or 225 mics per kilo, if I'm not mistaken. So I think the dosing is fairly similar to Novo7. The main difference, again, being the source of the material and how that may translate into different cost of manufacturing and ability to manufacture. I think it's really what they were after there.
The company is looking to see its utility in the context of a patient on emicizumab with regards to thrombin generation as well. So,
yeah. The other thing I would say about it is to the best of my knowledge, and Robert and Stacy, correct me if I'm wrong, I believe it's only approved for hemophilia A and B with inhibitors. I don't think it has approval for the other entities, for example, acquired hemophilia, Glanzmann's, that sort of thing that Novo7 has approval for. I think it's limited just to hemophilia A and B with inhibitors.
Yeah, that's correct. Some good, I guess, practical questions about emicizumab. So there are some weight ranges where it's difficult to dose by the vial. So how much of a plus minus percentage do you permit? Do you always round up or down to the nearest vial, or do you waste parts of vials? Maybe we'll get both the pediatric and adult perspective on that.
All right, I'll start out on this one. So we definitely have to round. Initially, that was something that the company couldn't really comment on because they don't want to be seen as inducing rounding up in it for any reason. And so there is a calculator on their website that helps you decide what's the appropriate dosing. So that's nice. But I can tell you that we've dosed patients after the loading dose somewhere between 1 to 2 per kilo weekly. And then on the every 2 week, we can dose somewhere between 3 to 4 per kilo weekly, or as low as 2 to 4. And we have not seen any significant differences. Remember the dosing, as you know, Stacy, the dosing that they chose was meant to achieve a specific outcome, a primary outcome of having the majority of patients having a 0 ABR. And so it wasn't meant to be this magical dose that everybody has to follow perfectly. But certainly everyone should attempt to dose as close to the label and then adjust afterwards. But, if somebody comes in and they're at 1.5 per kilo weekly, and now they're at 1.3, I'm not changing the dose, probably for at least another 6 months or so in the growing child. And I certainly haven't seen any bleeding issues. We tell the parents that they're dosing slightly below the label. And so if they start to have anything that they notice, then we just round up.
And we do the same thing in the adults. We don't, we round to the nearest vial size. We don't waste any of the product. We don't probably have the same amount of issues. Our patients generally aren't growing as children are. And it's a little easier for us to get pretty close to what the dose calculator recommends in our adult patients, but we also wouldn't want to waste any. And then we have a few that if the dose that is close to the vial is just a shade under, honestly, I don't think there's any data to suggest that's not good enough, and we certainly haven't seen any consequence of that. So as long as it's pretty close, we're going to go ahead and just not waste any.
Yeah.
We also have a question about changing among factor concentrates, in particular changing from SHL or standard half-life concentrates to extended half-life concentrates, and what the immunogenicity, what the risk of inhibitor development is for individuals who perhaps had previously had an inhibitor and tolerized on a product. Do we see increased rates of risk of inhibitor recurrence with switching from the standard half-life to extended? And perhaps we could comment, though this wasn't asked specifically, but comment on our A's versus our B's.
Yeah, certainly there's more information on the A's. The B's are definitely a sort of unknown. But, as you know, Stacy, in the Athens 2 study, which they looked at patients that switched specifically from one product to the other, there were patients with inhibitor or had a previous inhibitor and had switched products. And this was a real world study looking at whenever the patient and the provider decided to switch products. And they could switch, they just had to switch to a recently developed product. And there were absolutely no inhibitors seen in there. And so there wasn't a large group of patients that previously had an inhibitor and were sort of long-term tolerized. I certainly would not switch a product early on post-ITI prophylaxis. I probably would wait a few years or so before I would feel comfortable just personally. But certainly someone that was tolerized 10 years ago, I have almost no concern of them developing inhibitor if they switch back and forth from an inhibitor, standard half-life to an extended half-life product on the A side. And we have done that on hemophilia B side as well. We certainly wait a year or two after they've achieved tolerance, just out of utmost safety, because you put so much work into this, you don't want to lose all that. And so we have experience in which we switched products and have not seen development of inhibitor in the hemophilia B patients.
And I would agree with Robert. Obviously, on the adult side, it's a little bit different. It's extremely unusual for us to inherit, so to speak, a patient with an inhibitor that wasn't years ago. So most of the patients that we have that have inhibitors in the past, it's a long ways in the past. I will say when the EHL drugs first came out in 2014, we probably thought a little bit more about it. I can't say that I ever really worried about it, but it was certainly something that we talked about and we talked about with patients. Over the last 6 years, we just have not seen any data at all to suggest that it's a problem. And so I would say it's sort of a non-issue at this point for us on the adult side.
And I would add,
A and B.
and I would add that you should probably, in the subsequent visit, get a good washout and measure an inhibitor in that subsequent visit just for surveillance purposes. Yeah. And, at least, have that data because that's important for us, to potentially, study retrospectively.
And just to make it clear, when you mention for those tolerized, we really mean full tolerance. So this is not a pro inhibitor and perhaps some level of partial tolerance, but really achieving a normal or near normal half-life, certainly in excess of very short 6 hours before thinking about doing this and maintaining that. And I guess that actually, I didn't know how I was going to dovetail into it, but that works. Robert, you mentioned a very broad relapse rate of 2 to 25%. And the question is, over what time frame are you looking at relapse rates? Is it a high proportion of relapse tends to be in the first year or first 2 years, or is it sort of a broad range over the remainder of the lifespan?
A part of the problem of determining the exact amount is that this was this was just an observational study, essentially a chart review. And so some patients come more frequently in their follow-ups and some patients may be followed less frequently. And so it's hard to determine exactly, but typically that relapse is going to be fairly early. We have those patients that we really worry about if they stop prescribing, they stop filling those scripts and they are recently tolerized, we get really nervous about them potentially losing that tolerance. And so, so I think the concern is really once you've achieved all three of those characteristics, negative inhibitor, a good peak, an appropriate peak of 66% or higher, and having at least a 6-hour half-life. I think for me, I worry about those patients for about a year or so afterwards, and then worry about them much less after 2 years following ITI. So it's really in that first couple of years that they really need to be very vigilant about maintaining the post-ITI prophylaxis.
Excellent. So I know we're coming up on the hour, but I'm going to try to squeak in just a couple more questions. So Robert, from all of the studies that you presented and various schemas for potentially looking at ITI in addition to emicizumab, are there any inhibitor titers or patient characteristics that might prompt you to just dissuade individuals from doing ITI and switching over to emicizumab, or are you more of the opinion that ITI and emicizumab for all is worth a try?
Yeah, so I don't think it's for everybody. We certainly have patients that, if they have an existing high titer inhibitor of at 2 to 500 right now, and they've undergone ITI for a decade, I think the chances of us tolerizing them are pretty slim. And certainly the families have been exhausted, and once they start emicizumab, they may have zero interest when you bring them back 6 months later and have that discussion about ITI. And so, but we've seen other examples of my colleagues that there was an example of a patient in his 20s who moved from a developing country to the US, had a history of a high titer inhibitor, and was able to tolerize with this protocol within 6 months. And so you think, well, I shouldn't totally, eliminate those patients and the possibility. And so I think the characteristic is really whether the family are willing to take this on for sure. And we certainly had one patient who was 12 who had undergone ITI 4 times before we offered the 5th time. So I'm actually shocked that they actually did it. So, and he's been successfully tolerized and is only on once a week factor 8 post-ITI prophylaxis. So I think it's those patients that have had, really bad infections with lines. They're not willing to put in a central line for this because certainly you may need that. And then whether they're really high titer inhibitors, there's like the high titer and then there's the really high titer inhibitor patients.
Yeah, absolutely. And you sort of answered this, but I guess just to close it out, I think looking at ITI is academically very interesting in the context of emicizumab and our current options of care. practically from a patient perspective, like you're saying, ITI is incredibly time intensive and potentially stressful. It may or may not, even with these reduced frequencies of infusions, may require consideration of a portacath. What are your impressions about likelihood of patient full recruitment of these studies and patient interest in participating in something like this, just given the burden of ITI?
Yeah, I mean, we all know the studies about the burden of the morbidity and mortality of an inhibitor patient in the pre-emicizumab era. And those are certainly, things, those are all reasons to really force ITI on people because we know what could happen in the future. I think it's still very clear when you look at some of the safety issues, although they're significantly mitigated by emicizumab, there's still some lingering safety issues, and they almost always are in patients with an inhibitor. We were sort of moved by a patient that had a low titer inhibitor and developed an epidural hematoma while on emicizumab, and so patients can still have life-threatening bleeding events. And I think that inhibitor, although the rate and the sort of frequency of those life-threatening bleeding events is significantly reduced, I think if you're 2 years old and you have a high titer inhibitor, I think you're going to have some risk of life-threatening bleeding events, by the time you make it to Mark's clinic, and certainly in the 50 years after that. And so I certainly don't want those families to regret not attempting ITI when they're 18 and maybe it's not going to be it may be futile at that time. And so, yeah, it's a very difficult discussion. We weigh the risks of central line placements. So it's really like a long discussion, multiple visit discussion for sure. So, yeah, ultimately the family's going to decide this.
I would just quickly add that, from the adult treater's perspective, even though emicizumab has been a major game changer for our inhibitor patients, we would still very much prefer patients not to have inhibitors long term. I think about managing the medical comorbidities that come with aging and need for surgeries. It's very difficult to do that in an inhibitor patient. So it's not just about prophylaxis and preventing bleeds. It's about managing all the other stuff that happens along the way. And as Robert said, it's 50 plus years of it now. So if you guys could just get rid of those inhibitors, we'd sure appreciate it.
They're on it, Mark. Unfortunately, it's time to close
therapy. So.
I know, right? Unfortunately, it's time to close the section. Many thanks to both of you for excellent presentations and discussion. And thank you to all of those who joined us. Have a great rest of your day.